Good afternoon, everybody. This is a paper that it's a large database review. We presented it at the American Hip Society this year. I'd like to acknowledge my co-authors, particularly R. Presley Swan, who is one of our fellows. He's now in private practice in Indianapolis. Here are my disclosures. They haven't changed from this morning and don't really apply to this particular talk. So why is this important? Well, hip arthroscopy we know is on the rise. There's a pronounced change in how trainees look at advanced education in adult reconstruction and hip arthroscopy. There's studies now in the U.S. literature that show rapidly increase use of this technology in practice. This is a study on Part 2 board takers, a 600% increase in the utilization of hip arthroscopy over a 4-year period. And we know that arthroscopy is not without complications. As you've heard already this morning, the reoperation rate in various studies has been estimated in the range of 6 to 13% by a couple of different authors. And you heard very nicely from Lorenz the reasons for reoperation, which include all of these things: adhesions, residual structural deformity, laxity, and then of major interest to us is what is the real conversion rate to total hip arthroplasty in patients who have previously undergone hip arthroscopy. So the purpose of our study was to identify the conversion rate from primary hip arthroscopy to total hip replacement, to try and identify some risk factors for failure, realizing that because this is a large database analysis, there's some limitations with that, and we'll talk about that at the end. And then we wanted to look at the rate and perhaps the risks of revision arthroscopy. So the study design was a retrospective cohort study looking at the institutional base for a healthcare system in Utah called Intermountain Healthcare, or IHC. We looked at secondary data from their institution from 2003 to 2014. Intermountain Healthcare, for those who don't know about it, it's a vertically integrated healthcare system, which in the United States is somewhat unique. That means that this company owns, but is not for profit. They own the hospital, the doctors, the insurance company, and the employees, so they pretty much control care and cost from top to bottom. And it's been widely held up as one of the type of systems that would be successful under some of the new healthcare changes in the United States. So the methods, the inclusion criteria, we looked at for the first primary hip surgery for each patient, so a surgically naive hip, which encompassed these following CPT codes: femoroplasty, acetabuloplasty, and labral repair. The exclusion criteria included previous surgery on the hip, prior trauma, and then CPT codes that included any type of peritrochanteric work, such as IT band release, bursectomy, or work on the gluteus medius. The statistical analysis was again univariable and multivariable logistic regression to determine which factors were associated with conversion to total hip and reoperation. The predictors that we looked at specifically were age, sex, BMI, ASA score, which is really a surrogate measure for patient comorbidity, and then surgeon volume, where we defined low surgeon volume as less than 100 cases per year, and high surgeon volume as greater than 100 cases per year. So here are this is the patient population we started with, 1,452 patients. 394 of those were excluded, who were operated on by 21 surgeons for a number of reasons, mostly incomplete data or extremely low volume, which we defined as less than 3 cases. So this left us with a little over 1,000 hips. And if you notice at the bottom left, the conversion rate over this time period with this database, the conversion rate to total hip replacement was 9%, leaving 91% of hips survived. The mean time to conversion to total hip replacement in this population was 1.35 years, with a range of just over a month to 7.8 years. When we look at the patient characteristics for conversion to total hip replacement, the things that stand out are the failed hips, or the converted hips, were substantially older, with a mean age of 54 compared to a mean age of 38 in the survived hips. The male percentage was about the same, and then BMI, slightly heavier patients in the failed hips compared to the survived hips, although it was statistically significant, a question of whether that's really clinically significant. So overall, hips that were converted to total hip replacement were generally older patients, slightly larger patients with higher ASA scores indicating higher levels of comorbidity. When you look at that graphically, the risk factor for conversion to total hip based on age, essentially there was a 3% increase risk of conversion to total hip with each 10-year increase in age. ASA score, again, the surrogate for comorbidities. Patients who were converted generally were at ASA scores between 2 and 3, whereas those that had survived were healthier patients with ASA scores predominantly with ASA 1. The odds ratio with the multivariable analysis was essentially 2. When we look at, this is probably the most striking finding, risk factors for conversion to total hip based on surgeon volume. For those surgeons performing less than 100 cases per year, the conversion rate was 12%, and for greater than 100 cases a year, it was 4%, for an odds ratio of 2.34 associated with conversion to total hip. When we look at revision arthroscopy, these rates are slightly higher than what's been reported. A 20% rate of primary hip scopes undergoing revision arthroscopy within the system. When we look at, again, the risk factors, age, younger patients basically had a higher risk of going on to revision arthroscopy, and that was really the major statistically significant finding. So if we look in the literature in terms of conversion to total hip, as I said, the rate has been variably reported as 1.3 to 9.2%, with risks including increased age, increased BMI, labral resection, chondral damage, and residual structural deformity. Our data was a little bit on the high end of this with a 9% rate of conversion. We found very similar risk factors for conversion to total hip replacement, namely increasing age, heavier patients, sicker patients, and lower surgeon volume. When we look at revision arthroscopy in the literature, the rate has been estimated at around 6 to 13%, with the risks being younger age, increased BMI, and residual structural deformity. We weren't able to look at that last factor because this did not include a radiographic review, but our rate of 20% revision just within this healthcare system was higher than what's been reported. Certainly there are limitations to this study. Again, when you're looking at big data analysis, you can't really find indications for surgery. We were unable to look at x-rays. And really, we can only look within this healthcare system for patients who have gone on to subsequent operations, so these numbers may actually underestimate the true failure rates. When we look at just our own University of Utah data, where we have 2 hip arthroscopists performing a fairly high volume, the numbers look a little bit different, and I just threw this in for comparison. You can see we've analyzed now close to 700 hips within our own healthcare system. The reoperation rate is lower. These are both fellowship-trained hip arthroscopists. It's 11%. And if you look about halfway down, the hip arthroplasty conversion rate is 1.3%. So quite a bit different data than what we see in the other larger healthcare system that we analyzed. In the future, we want to look at clinical and radiographic factors, obviously, for failure, especially with how it relates to the total hip replacement group. And we'll continue to compare and contrast this data with our own internal group. Thank you very much for your attention.